Good evening, everyone. I'm Carolyn. I'm one of the newly hired intensivists. Welcome, and I'm actually trained in both internal medicine as well as ICU, and I find it's a very fortunate opportunity to work with the Belleville General family, and we're hoping that this presentation will hopefully answer some of the questions that you have about what the ICU does. And part of what we do in the ICU is to care for patients who had undergone cardiopulmonary resuscitation. And I'm going to elaborate on that. So cardiopulmonary resuscitation, or in short form, is CPR. It involves at least a minimum of some form of chest compressions, as well as delivery of artificial breathing devices to help maintain blood flow, as well as oxygen while the heart has stopped working. And the first question everyone always asks is, who gets CPR? Well, in a very majority of patients, those who had undergone a cardiac arrest. However, you've noted that there's an asterisk there, and it's because sometimes there's also a small population of patients who undergone respiratory arrest, meaning breathing difficulties and therefore requiring some form of resuscitations. There's also another population who don't get CPR, and it's something that Dr. Reddy will talk about in her next presentation. Well, what we do when we do CPR, it's actually called code blue in the hospital. Essentially, it's an emergency resuscitation, and it involves either CPR or defibrillations, meaning us delivering a form of electricity to kind of jumpstart the heart again. And we also deliver some form of airway devices and also breathing support. We also use very special drugs, again, to kind of jumpstart the heart. Also delivery of fluid or blood products or any other support medications the patient needs. And we always do this in a continuous monitoring and reassessment environment. Who comprise of a code team? When you see on TV, you also see a group of people rushing to the patient's room, and it seems crowded and chaotic. However, it's actually a team of individuals comprising of a co-team leader, usually a physician, nurses, respiratory therapists, anesthesiologists, and also other physicians, resident doctor, medical students, pharmacists, sometimes the chaplain and social worker if the family needs, as well as personal support workers, anyone that is able and willing to help to take care of the patient during that situation. And again, to emphasize, this is a team effort. No code blue can go without an efficient and also highly dedicated team working together in sync to save the patient. How long is a code blue? That actually depends. It depends on a lot of factors. One is what we call downtime. This is kind of a jargon that you will hear sometime when doctors talk to each other. It's a duration of time when the patient was last seen being well, or at least have a pulse, and a time when the patient was noted by anyone, including nurses, to be absent of a pulse. The duration of downtime, the longer it is, the harder to bring the patient back. And sometimes it plays a big factor in how long we run a code blue. But other factors also are important. For example, the comorbidities or other illnesses the patient have, how far in advance their illness is, and what are the causes or mechanism of the arrest. Obviously, cardiac arrest, meaning when the heart stops, it's harder for us to resuscitate a patient than other form of arrest, including respiratory arrest. Age, and I have in their bracket physiologic age, and again, it's not age of a number, but age in terms of how many illnesses and how far in advance the failures of the other organs are functioning. And also family wishes, that's actually play a very important part in our decision as well. So the next question is, how many actually survive a code blue? In ER, health, and the other medical shows, the number is very good, 65 to 75%. But unfortunately, in real life, we don't have as good of a number. And despite decades of us being more aware, more trained, more ready to deal with a code blue, the number still is very small. So anyone who actually had a cardiac arrest and actually survived to hospital discharge, you can see the percentage is very small, about 15%. And obviously, the percentage is a little bit better for patients who had undergone respiratory arrest. So it's definitely not as good as we would have thought based on media, TV, or movies. And so after the patient who's been resuscitated successfully, we bring them to the ICU. Definitely very different from the first few early days of the ICU. Now we see more tubes, more machines. Though they're very scary to look at, but they are actually a very essential part of saving the patient's life. And I just want to do a brief introduction of what we actually do in the ICU. So we're there to provide life support. What life support is actually an aggressive and invasive resuscitation. We continuously monitor the patients and continuously tailor our therapies as the patient needs. That involves mechanical ventilation, which I believe one of the respiratory therapists will talk about later, and also specialty drugs, things that we cannot provide outside the ward that can raise the heart functions, raise the heart rate, raise the blood pressure artificially, and at other centers, also dialysis. And we always provide artificial nutrition and hydration to the majority of our patients when they're in the ICU. So I'm just going to give you some pictures of what some of these devices. This is one of the ventilator. This is the BiPAP machine. And these are what we call central lines. So these are bigger than the IVs that we normally give the patient, and they are to deliver those specialty medications. And this is the NG tube to give them some form of nutrition. And often I get asked, well, what can life support actually do? Well, definitely it can temporarily stabilize the body, let it have the time for it to heal and to recover, and also to resume the normal functioning. We definitely, however, don't have the magic pill yet. We don't have the miracle pill to give at this point. And we definitely, unfortunately, cannot fix something that's completely broken. And even though we wish to as doctors, but we're not there yet. So what happened after we resuscitate someone successfully? Is it a smooth road ahead? We wish we could say that for sure, and we always try to prevent complications, but complications happen. Some of those complications include brain injury, the heart having dysfunction, or other organs, including kidneys, livers, lungs. And we also experience metabolic derangement and infections. These are the challenges that each and every ICU patient has to face in order to survive. Well, what about life after the ICU? There's good news. The advances that we have made in the ICU so far is allow us to say that the neurological recovery in the majority of patients, 69% actually in this population that's been studied, is good. And 70% of the patients is actually neurologically stable. But what does stable mean? Is stable good enough? And I think we need to be more specific about what it means. So I'm going to introduce to you a few studies. One of them here found that the people who survived to discharge, even though they are considered quite neurologically improved after the arrest, they still suffer some form of minor problems. Minor, but yet significantly impacting the quality of their life. Even problems with memories, or needing assistance to be able to function independently at home, or whether resume work function. And not just the physical recovery that they need, but also the emotional recovery is also a long journey. Some of them would experience fatigue, or unfortunately depressions, anxiety. And we're becoming more aware that outpatients who leave the ICU are often experiencing what we call PTSD, or post-traumatic stress disorder. And one of the studies actually found that the patient who leave the ICU, survive the ICU, actually experiencing this disorder almost twice or triple the rate of people who are recovering from a heart attack. So what does that mean? We have improved over the years our care, and we have improved over the years the outcome. But more and more research is needed so that we can improve on the actual functioning of our patients once they leave the ICU. And it also poses a very important questions. If we're facing all these challenges, and our patients facing all these challenges, should we or should we not have discussions about resuscitations? And I think that's what Dr. Reddy is here for.